This excellent medical student-led podcast is for educational purposes only and not intended to be used as medical advice under any circumstance.
Hello, everybody. Welcome back to the Alert and Oriented podcast. I'm Nathan Kudlapur, here with my co-host Koushik. We've got our leader-in-chief, Kevin Grudzinski, and some fabulous discussants joining us on the show. We'll introduce them in a moment here. How have you been, Koushik? It's been a few weeks since we recorded our last one.
Yeah, man. So far, so good. You know, the weather's starting to turn, which is nice. We got a week of 50s until next week, presumably, we'll be in the negatives. But, yeah, everything's going well. How are you, bud?
Nice. I'm good. I have been reading through Lord of the Rings. So I'm halfway through the first book, Fellowship of the Ring. It's been pretty cool.
Yeah, that's awesome. I hope that you're able to get through it in the next 5 or so years, because that's about how long it took me.
Yep. All right, well, we'll go ahead and let our discussants introduce themselves.
All right, I can start off. Hello, everybody. My name is Saihej. I am a medical student here at Feinberg. I'm between my 3rd and 4th year, and I'm currently doing research in inflammatory bowel disease.
My name is Fikayo. I'm also between my 3rd and 4th year here at Feinberg, and I'm finishing up some research with the ortho team.
All right, we're excited to have you guys on today. So we've got a riveting case, and I will go ahead and let Koushik kick us off.
Alrighty. So we always like to start delightfully broad. So for our first piece of information we'll give you guys, we have a 25-year-old patient, a male patient, who presents with a fever and headache. And that's all we're going to give you right now. Right. So basically what we would love to hear from you guys is how you take a really broad chief complaint like this and basically make it manageable. So how do you start to initially frame your thoughts, and what do you think right now?
So yeah, to start off, I feel like it's good to think in terms of like different buckets, different systems that you're thinking about. So I would think about like neuro, for example. I could be thinking about meningitis, especially when we're considering the patient also has a fever, which could also yeah, especially also considering the age. And then another thing that I was thinking about is like, just because it says they have a fever and headache doesn't mean that those two have to necessarily be related. So like,
that's true.
That doesn't mean that things like a migraine or a tension headache is off of the differential.
I agree. And then I think kind of broadening the scope, we can think about infectious etiologies. We can think about not just meningitis, but other things. We can think about rheumatologic problems. I think that's it for now.
And like from like kind of an ENT perspective, like sinusitis, like that's probably like the most common thing that you'd see if you see like a 25-year-old with fever and headache.
I guess first thing I think about, given that it's November, is like probably like flu, COVID, things of that nature. And then we can just like move from there.
Yeah.
100%. I think that what you guys said made a lot of sense to me. I feel like the general pattern that I've seen and the way we like to frame these, especially really broad chief complaints, are in terms of thinking of buckets. I feel like especially where we're at in our training, that's a really helpful first place to start. So I hear you guys kind of thinking about a possible infectious bucket, a rheumatologic bucket, a neurologic bucket, and then kind of framing the likelihood within each of those things, thinking about common things being common, but especially Fikayo, straight fresh out of step 2 studying, always thinking about the zebras and what it could be from the parking lot. So and that makes a lot of sense.
Yeah. I think if like I saw this in clinic, I'd be like thinking about those more common things, like especially, but since we're on this podcast, I feel like you're probably trying to trick us a little bit.
Little podcast bias.
Exactly. Okay, so it sounds like we got a good start going. How about a little more information?
Sounds good.
Okay.
All right, so we've got some more history here. He's been having 2 weeks of fevers and right-sided headache. He also endorses chills, full body aches, and fatigue. There's no significant past medical history. In terms of social history, he immigrated to the U.S. from Venezuela 2 months ago. During the journey, he waded across a river in knee-deep water. He's currently staying at a friend's apartment, and friends report they have seen occasional mice at the apartment. He's up to date on vaccinations. He's a former smoker, has occasional alcohol use, no illicit or IV drug use. So, what are you thinking now?
This is one of those you were throw every single risk factor.
I feel like with the social history, like adding that they immigrated from a country in South America and that they have like exposures to being in a river in knee-deep water, you have to really think deeply about like different infectious causes and maybe widen what types of infectious diseases you could be thinking about.
But I also wouldn't rule out any neurological causes as well, or like neurological manifestations of those causes, just because the headache is unilateral. So maybe later down the line, probably think about some imaging.
Are there specific infections that you're thinking about right now based on some of this history?
I feel like I haven't really narrowed down on anything specific yet. Still thinking about like meningitis. So like some of the more common ones, like Neisseria in like a younger patient. But yeah, I haven't really narrowed down on anything specific.
Because of, I guess, the location, I'm considering some fungal etiologies that I can't remember the names of right now. But I don't notice any like diarrhea or like, well, specifically like bloody diarrhea or anything else like that in the stem. So I don't know. I'm kind of gonna table that for now. Maybe wait for some more information.
All right. So sounds like you guys still keeping a broad differential, still considering neuro room things, still thinking about infectious things, but realizing that, maybe our net of possible infectious causes is wider than we initially thought.
Yeah.
So,
2 weeks of fevers is also pretty concerning. So that lowers like a viral etiology down on my differential.
Yeah.
And then raises like bacterial or fungal for sure. Yeah. Let's go with that.
Okay. So when you go to see the patient, what would be something you'd be looking for specifically on physical exam, and what sort of like initial labs or imaging would you think to order?
I think like you'd be looking for like nupal rigidity in terms of like assessing for meningitis. I would do like a neurologic exam, see if they're having any like neurologic deficits.
Besides like the unilateral headache, I would try to see if there are any other focal neurological defects. Maybe stool sample, see if there's any blood in their stool, but maybe they haven't noticed it because it's like, I forgot the word.
Occult.
Yeah, there we go. A call. Thank you.
Also, like I feel like checking their vital signs, checking like their blood pressure, see if they're septic, and see how sick they are. The vitals would be really helpful with that.
All right. So Koushik, you want to give us some of that?
Yes, sir. So, starting with the physical exam, for vital signs, the patient is febrile to 103, heart rate is 85, respiration's 18, blood pressure is 118/65, satting at 97% on room air. Generally, they appear their stated age, they're sitting up in bed, no acute distress. On HENT exam, pupils are equal and reactive bilaterally, extraocular movements are intact, no scleral icterus, membranes are moist. On neck exam, there's no nuchal rigidity, there is no cervical lymphadenopathy. On heart exam, you appreciate regular rate and rhythm, no murmurs, rubs, or gallops. Lungs are clear to auscultation bilaterally, no wheezes or crackles, normal work of breathing on room air. Their abdomen is soft, non-tender, non-distended, no hepatosplenomegaly. Skin exam shows no lesions or rashes. Extremities are warm and well perfused, no edema, no joint swelling, no Janeway lesions or Osler nodes. And on neuro exam, they are alert and oriented.
Yeah.
Haha. Never gets old. ×4 with no focal deficits on neuro exam.
So it sounds like this physical exam's not giving us too much to work with.
Yeah.
Correct. I actually have a couple more labs for you guys. For their CBC, their white count is 8.9, hemoglobin's 12.9, and their platelets are 199. BMP is normal. Chest X-ray shows no acute cardiopulmonary process. And you were just saying that the physical exam doesn't give you a whole lot to go off of.
Neither does the lab.
There you go.
So we have a pretty high fever. I mean, blood pressure seems fine. Diastolic's a little low, but I mean, then that could be as normal. So we're thinking febrile for 2 weeks, once over Venezuela, unilateral headache, no focal neurological defects, no bloody stool, at least for now.
Yeah.
I can't think of any, like no signs of, I guess, seizures or fainting.
Yeah. I just like wonder, like with this patient, like having the fevers and the headaches, their age, like their fever's that high, even though like we don't really have information that like is super suggestive of like meningitis, would you still get like a lumbar tap in this patient? Just because like that's something you don't want to like miss.
Yeah.
Yeah, absolutely. I feel like this is a little bit of a difficult physical exam and initial labs that we threw at you guys because a lot of it is negative. But it sounds like your suspicion is still high. You don't want to rule out some of those really scary things like a meningitis, especially with the fever. So one thing that I actually want to ask you guys is, you're seeing this patient in real time with a, largely negative exam, but still with this high fever and these initial labs without a profound leukocytosis or anything like that. But how worried are you about this patient when you're seeing them, even with this initial information? Is this someone who you're still really worried about, or how are you triaging them in your mind?
I feel like because he's made it 2 weeks with this fever and just a unilateral headache, and we're not seeing much else on exam, and it's kind of sounds like it's continued to be like this. I'm not super worried. Something that just came to mind is, how often are his fevers happening? Do they go away and come back, or are they just like constant? And then like that kind of makes me think about a malaria picture, which is very concerning. So we'd probably want to test for malaria as well.
Yeah, I agree.
Okay, absolutely. And actually, to piggyback off what you were just saying, Fikayo, was a really, really great point. So, Saihej, you mentioned wanting to potentially get spinal tap and some CSF studies. Fikayo, you mentioned that malaria is kind of on your differential now. What would be your next steps for this patient? Any other imaging you want? Any other labs you want to order? Anything else you want to look for on exam?
I say we get the CT. So we get the CT. Bunch of what's the word I'm looking for? See, this is why I shouldn't be on the class. I just forget words.
What was it?
What is the test for malaria?
Oh, is it like blood smear?
Yeah, there we go. Blood smear. Damn, thank you.
Yeah.
Sorry, you're gonna have some.
Yeah, I agree that it would make sense to like, well, we have to get the CT for the lumbar tap, but also just like, I feel like the threshold for getting a CT for a headache, like in the ED or in the hospital, is like not too high. So I would probably start off with that. Maybe like no need for like an MRI or anything at this point. And then probably run like a wide ranging like infectious panel.
Yeah.
I feel like, I mean, that's just like this high of fevers with the history of like recent immigration going through that like river, like
Yeah.
Why don't you elaborate on that? What is your infectious workup going to be?
like you could do a stool ova and parasite, look at the blood smear for malaria. I don't know what the specific test is, but probably test for all those like endemic fungal things like coccidioides and histoblasto, toxo. Yeah, I'm still like just keeping it so broad because the physical exam's like not really giving anything.
Yeah.
Do we consider like
look at.
Yersinia too? Because the mice, is that something we can consider?
Yeah,
I don't
it's
know.
good
Yeah,
thought.
I forgot about the mice. That's a good point.
I don't know. I'm just pulling
Nice
at
river
strings
sun.
here. Yeah,
Yeah.
all the risk factors.
Do you want to start any medications for this patient while you're waiting for all of that lab workup to cook?
Some empiric
Yeah,
antibiotics,
empiric
perhaps.
antibiotics. I would feel like
What are you covering?
everything.
Yeah, something broad spectrum. Do we? Because
What would your
We should do, like,
treatment be for?
Would it be ceftriaxone and azithromycin?
So you acquired pneumonia?
yeah,
I forgot what we gave on the wards for a patient who we were worried about, like meningitis, like fever
Okay.
and headache.
So empiric coverage for meningitis.
Yeah.
Okay. Ceftriaxone.
What's the other one?
think.
Bang. Oh yeah, yeah. So I would probably start with that.
And if you want to get viral coverage from meningitis,
Say cyclovir.
yeah.
Yeah.
And then depending on age, peds and really old people, you think about adding ampicillin for listeria coverage, but he doesn't really fall into that demographic.
Okay. All right, guys. So, as for some pretty great next steps in workup, wanting to start this patient on empiric antibiotics and an antiviral. So, let's see what happens, shall we?
Sounds good.
So, this patient is started on Vanc, ceftriaxone, and acyclovir,
Nice.
but you don't notice any effect on their fever curve. So, they're still spiking daily fevers. So, Fikayo, to your point, with the frequency of the fevers, they are daily. You also get a liver panel with an ALT of 22, an AST of 20, a T-billy of 0.5, ALK-Phos 150, and albumin of 3.2. You get coag studies that show a PT of 15.9, INR 1.4, PTT 30.4. Your other labs show an ESR of 58, CRP of 118, ferritin 138, ANA is positive with a titer of 1 to 320 with a negative reflex. ANCA is also negative. You draw 2 blood cultures, both of which are negative. RPP is negative, and the UA is non-infectious. So just threw some labs at you guys.
It's a lot of labs.
Yep. What sticks out to you?
I think the ALK-Phos is high. ESR is high. CRP, CRP is high. Yeah. ANA is positive. So we're definitely thinking rheumatologic picture or something rheum involved, maybe. PT, I think is fine. INR should be okay. I don't think it sticks out that much.
Yeah, I agree that like with the positive ANA, like we should definitely start considering that room bucket as well.
Yeah.
Especially as our like infectious workup continues to like not give as much, and they're not having the empiric antibiotics, antivirals aren't really having an effect on their fevers. And also, I guess like probably we might want to get like a broader history of, you know, what types of like symptoms they've been having. Has this happened before?
Yeah.
I love that point. Because I'm gonna get on my soapbox for a second. An ANA in isolation is a horrible test. So many people, I forget the statistic, but are going to have a positive ANA. The titer is important. The higher the titer, the more likely that something, it is a true signal versus not a signal. But I think you just raised the most important point is when I see this result in isolation, it means go back and do a more extensive review systems. Figure out if they are having any rheumatologic type symptoms that can help support the ANA being positive, because we know people are going to have positive ANAs without autoimmune disease. Maybe it's early, maybe they go on to develop autoimmune disease, but in many cases, that's not the case.
Yeah.
So I think going back to the bed, talking to the patient more, figuring out if something else has been going on, joint pains, rashes, nerve loss, stuff like that, can make you go down the rheumatologic bucket then, but if you're not getting that, it's really hard to interpret that test.
Yeah.
And also for reference, this titer is like on the lower side.
Okay.
Yeah.
So looking at the ESR and the CRP, which you guys both pointed out and seem to be looking at right now, those both look pretty profoundly elevated.
Yep.
How do you synthesize those? How do you like interpret that in the context of the case? Because these are also two good tests I like to talk about.
I was thinking like, can't they be elevated in like in any state of like increased inflammation? So like you don't really know if this is infection or like rheum's kind of like non-specific for us.
When I see ESR CRP elevated, that shows something inflammatory is going on.
Gotcha.
That's all you can say.
And then what do you make specifically of the liver panel and coag studies?
So these are the
Alk phos is high.
elevated. Can I get the normal reference ranges for the coags?
There.
It's been a while.
Yeah.
I think that ALK phos is like very mildly elevated, like very mildly, and then INR normal is 1, right? Because it's a normal ratio, so it's really elevated. And then the PT is a little elevated, but that's just supported with INR.
Yeah. So you have elevated PT and INR, a little bit elevated ALK phos. The albumin is also slightly low.
Well, I feel like none of the lab markers that are like markedly abnormal. So I don't personally know if that's giving me anything to really work off of.
And isn't it possible that they're just a little bit elevated just because of like the big picture inflammation or some sort of reactive phase thing going on?
Possible, unlikely. I think when I'm seeing this using in the context of the case, so low albumin, a little unusual in a younger 25-year-old, otherwise healthy. Same with a mildly elevated INR. When I think back then, this patient's been traveling for months.
Yeah.
They don't really know what they've been eating. I think a first bucket to consider for both of these could be malnutrition. That could be the tie.
Yeah.
All right. So yes, actually what we ended up doing was the patient was given vitamin K supplementation and the PT and INR normalized. So when you think about the difference between these PT and PTT tests, so PT is prothrombin time, looking at the extrinsic pathway, specifically factor 7, and factor 7 is a like vitamin K dependent factor. So if you're deficient in vitamin K, you could see elevated PT and INR. PTT, on the other hand, is partial thromboplastin time, looking at the intrinsic pathway, specifically factors 8, 9, 11, and 12. Factor 9 is vitamin K dependent, but because looking at all these factors, it's not like the classic one we look at for vitamin K deficiency. That is generally indicated by the PT elevation. And then also because of the low albumin, that can also be an indication of malnutrition.
Yeah.
So those are sort of the clues going on here. So yes, we'll proceed with the case. So it's now been 2.5 weeks since symptom onset. Patient is still having daily fevers. However, the headache has now resolved. We got some other imaging that came back. So MRI brain is normal. Right upper quadrant ultrasound shows mild periportal echogenicity, no cholelithiasis or biliary ductal dilation. CT abdomen pelvis shows left periaortic lymph nodes at the upper normal limit in size, no definitive source of infection. An echo shows ejection fraction of 60%, no evidence of valvular vegetations. CSF studies are notable. We talked about this before getting the lumbar puncture. Notable here for protein of 35, glucose of 56, white blood cells 4, red blood cells 2. And the differential is 89% lymphocytes, 10% monocytes, 1% macrophages. Gram stain is negative, and the culture is pending. So it's quite a bit going on there, but how do you interpret these studies?
Is the protein high and the glucose low in the CSF?
Yeah, so let's jump to the CSF here. What are you making of these like CSF findings?
I'm just trying to like figure out,
Yeah.
like, at least like first thing I want to do is try to figure out what the cutoffs are so I know whether it's high or low. And I don't remember the cutoffs exactly, but I'm trying to guess. Is the protein high?
So here, actually, both protein,
And
glucose,
right?
and the cell count, these are all technically normal.
Okay.
What do you think about the differential on the cell count?
Why the lymphocytes
Like,
points me more of like a T cell direction. So I'm thinking maybe something like more like TB, more fungal, more viral etiologies
Versus bacterial.
versus bacterial for sure. Yeah.
If it was bacterial, what would you expect to see?
you see like the white count would be probably elevated, and then protein would be high, and the glucose would be low.
Yep. Yeah. Yeah, and we don't really see that pattern.
Yeah.
Yeah. Yeah. Yeah, you guys are like spot on with that analysis, and more on the differential. So normal differential, you expect to see about 70% lymphocytes and 30% monocytes. So you're right in noting that this is like kind of high in the lymphocytes, which you're right, could indicate like viral, could indicate like fungal or TB potentially. Okay. The other imaging results that we have, anything stand out to you from those?
So only thing that the only significant finding I see is the like mild periportal echogenicity.
Yeah.
And the TT looks normal EF. Like the left periodic lymph nodes are like the upper normal in size, but I don't think that's really a significant finding. So the only thing is that like mild periportal echogenicity, which even that doesn't sound very.
Yeah, so that should be like sort of
strong.
non-specific.
Yeah.
Yeah.
The echo, what do you think we were most worried about of like, and why we got this echo?
Like infective endocarditis.
Yeah. Yeah. We've had like negative blood cultures, no evidence of vegetation on this echo. This is like transthoracic, so it's not the highest sensitivity for endocarditis, but I think given our other labs, it's probably less likely. And if you remember to the exam, we mentioned there's no Osler nose or Janeway lesions.
yeah.
I mean, that can't rule out endocarditis, but this picture is sort of making that less likely.
Yeah.
Okay.
Where's all the signal pointing?
I think signals so far are still not. They're not really pointing as in an infectious direction, even though we've been doing like an extensive workup. So like we kind of talked about, I think it's time to like go get more history.
Okay. Well, you can click the next one. So, we sort of had been mentioning infections, and we haven't given you that many infectious labs. But now we get a very broad infectious workup that returns, and we have this for you.
As Saihej has been begging for the last 15 minutes.
So allow me to rattle through this for you. So the CSF culture was negative. CSF meningitis panel, negative. Malarial smear, negative. HIV, syphilis, chlamydia, gonorrhea, those are all negative. HSV 1 and 2, negative. EBV is positive, but at less than 35. So it's like very low, basically zero. VZV, CMV, enterovirus, negative. TB, Quantgol is negative. Hepatitis panel, negative. Zika, dengue, chikungunya, PCR, those are all negative. Leptospira, Bartonella, Coxiella, Brucella, Histoblasto, Cryptococcus, all negative. Global fever panel, negative. And even Carious testing comes back negative. So yes.
That's what I
You're
call
giving us-
comprehensive.
Yeah.
This is almost as comprehensive as it gets. I
Yeah.
don't even know what a global fever panel is.
Yeah. The global fever panel, for listeners' reference, covers chikungunya, dengue, leptospira, and then a variety of the plasmodium, so like malarial species.
Nice.
And then Carious testing, we've talked about on this podcast before, basically looks at cell-free DNA in the blood and then compares it to like database and checks like 100 to like, I think even potentially like thousands of different things.
Oh my goodness. Wow.
I don't know. This is like very comprehensive, but is there any specific infection you're thinking about could potentially be missed by this? Or do you think it's probably not infectious at this point?
Let me go down the list here. What type of syphilis testing did we get?
Probably the RPR.
Yeah, probably RPR, yeah.
I forgot which specific test it is, but in syphilis, isn't there one test that can be like negative, especially like early on?
I'm not sure, to be honest. I think of using RPR and reflux as like an initial screen,
Okay.
especially in the absence of any of like the cutaneous findings. I mean, we could go back to better sexual history to help support looking further, but I think I would trust this.
Yeah, usually, I think a negative test doesn't necessarily mean that they don't have a disease, but given that almost everything on here is negative, I think we can trust this panel unless we see, some big changes acutely.
Yeah, I mean, this covers a lot of things.
Yeah.
There are things that we're not catching here, which we should still consider. But fevers don't lie. This patient's been having a fever for 2.5 weeks.
Yeah.
And that's nothing to wave our hats at. And as defeating as this workup coming back negative might feel, I think we're going to have to keep pressing on.
Yeah.
Especially if they continue to fever while on antibiotics, while on antivirals. We're missing something.
Yeah, so at this point, the team is like, sort of almost going in the direction of thinking about getting a PET CT scan to look for potentially like malignancies going on driving these fevers. But just as you're just about to get that done, another lab comes back. So we have serum West Nile virus is positive for IgG at 4.5. However, the IgM is negative. And CSF for West Nile virus is also positive for IgG at 1.7, and it is also negative in IgM. So, what do you make of these labs?
I think IgM is like the first antibody to be positive for a test, and then like 4 to 6 weeks later, IgG comes around. So I think based on risk factors, it's possible that, they were exposed to West Nile virus when they came from Venezuela around 4 to 6 weeks ago. And that's exactly what this aliquot 7 is telling us. That's crazy. I didn't even think about West Nile virus.
Yeah. But this would, because the IgM's negative, like this isn't an active source of infection. So
Could be. Just could be that they seroconverted.
Yeah.
Yeah. So, what do you typically think of? You mentioned like IgM, you typically think that as like acute infection. So, yeah. So that's the question here. Does the West Nile virus explain all his symptoms?
I'm not sure how long the fevers for West Nile virus last, but I do know that, fevers are obviously one of the symptoms.
Yeah.
I think arthropathy is also one of the symptoms. Could I be remembering correctly? And I don't think we got that from the question stem, but we could ask about it. Maybe it's something that they didn't notice before.
And can you get like headaches and like neurologic issues with West Nile, right?
Yeah.
Yeah.
That kind of fits in with the picture.
Yeah. And what do you make of these IgG antibodies being present in both the serum and CSF? Do you think that's significant?
Yeah, it's pretty significant.
Yeah. Because it means like there's like a neurologic infection.
Yeah. All right. Well, you guys nailed it. That brings us to our, final diagnosis and case resolution here. So, diagnosis was West Nile virus meningitis. And this was based on the IgG being present in both serum and CSF. We also noted there was the high lymphocyte count in CSF, and also like some of the symptoms, having the headache, that also supports CSF involvement. So the PET CT scan was canceled. The patient was discharged with follow-up in 2 weeks. So, it's pretty wild. We went through all that workup.
It was an infection at the end of the day. So
Yeah.
wow.
Yeah.
That's crazy.
Any thoughts or reflections about the case?
Even with the broad workup, there's still something that sometimes can fall through the cracks. So you just gotta keep trusting your, medical gut and continue pursuing some sort of infectious etiology if all the evidence points in that direction.
And I feel like this is like a good case looking at like starting off really broad with how you're thinking about things and then kind of narrowing as you go down. And then even if you don't have anything pushing you in a specific direction, like you just got to keep pushing and looking like at more detailed, more specific stuff as you keep going.
But I do have a question about how do you kind of balance being thorough and also being cost effective for the patient? Because I could imagine that workup was probably very expensive.
That's a great question. It's something you have to think about.
Yeah.
I think in this case, young, otherwise healthy adult, if they were coming from Chicagoland with similar symptoms, that changes the picture than if they were traveling. So this is fever and traveler. So they're going to get more radical workup just from that little piece of history. And then I think what really drove continuing the work up here is the fever, the persistent fever of quite a long duration. I think once you kind of hit the 3-week mark, you start talking about fever unidentified origin. And with a comprehensive workup, that opens up a whole new bucket of differential diagnoses, which I'm sure we're starting to be considered. In this case, they were sure on a PET CT.
Fair.
So I think the fever, the fact of persistent fever every single day, while on antibiotics, while on antivirals, trying to keep looking because there's something creating that fever.
All right, it's going to wrap up with a few teaching points here. So we talked about this IgM test. And so, like we mentioned, we generally think of IgM as indicating acute infection. But overall, IgM is actually kind of an unreliable test for a number of reasons. First, the IgM is prone to getting false positives due to cross-reactivity with similar pathogens. So in the case of West Nile virus, for example, it could get cross-reaction with other flabby viruses like Zika, dengue, yellow fever, Japanese encephalitis. But that wasn't the case in this because IgM was negative. So actually it was more like a false negative. So that's another issue, is the false negatives, which is due to timing of IgM production and variability in immune response. So IgM starts turning positive about 3 to 5 days after infection and can start declining weeks to months after infection. But the rate of the decline is highly variable. So basically, if you draw the levels too early, maybe the patient hasn't produced enough IgM yet. And if you draw them too late, maybe either the levels weren't generated that well initially, or they were generated and declined very rapidly. So you have to, take caution when you're interpreting these. So for that reason, IgG may be more reliable for confirming infection. In general, for West Nile virus, if there's positive IgM, that's really good clue, but this case really highlights the importance of taking in the whole context, the patient's symptoms, when those began, the time course, and the presence in CSF and serum. So then just to close out a little bit about West Nile virus, so it's part of the flavivirus family, transmitted by the Culex mosquito. The first case was reported in 1937 in Uganda, but then the first cases in North America were noted in 1999. And actually it is now found in all 48 continental United States. So we actually can't think of it as just some tropical foreign infection. And in this case, it is most likely the patient contracted the virus when he was here in the US versus during his travels. So in terms of clinical presentation, most cases are actually asymptomatic. Symptoms only occur in 20 to 40% of patients. Virus has an incubation period of 2 to 14 days. And then the clinical presentation is sort of one of two categories. Most common is going to be something called West Nile fever, where the patient presents with fever, headache, myalgia, malaise, and maculopapular rash. This rash can actually occur up to 50% of patients. And then the more severe form of infection is the neuroinvasive infection. So meningitis, encephalitis, flaccid paralysis. And the patients that are most at risk for this severe disease are going to be age, immunosuppression, and malignancy. And then in terms of management for West Nile virus, it's going to be supportive. Generally, these cases resolve on their own without any other specific interventions. So, yeah.
That did bring up one question I had. What time of year did this case occur?
This occurred in the summer.
Okay.
Oh, wow.
Okay.
Yeah.
Would you still be concerned for West Nile virus, in the winter, if the patient was just in the United States? Or is this just something you're...
Probably less concerned if you're in the middle of winter. Yeah.
Is the West Nile virus part of any panels that Northwestern has that we know of? Or?
So it's interesting. It was not on the global fever panel, was not on the meningitis panel, and I actually looked on the Carious testing website. It is actually not detected by Carious, surprisingly.
Wow.
So that's why the Carious testing was likely negative.
Okay.
You got to think about it to diagnose it.
Yeah.
Yeah.
Wow.
Yeah. Well, great job, Saihej, Fikayo. Great
you.
having you on the show.
Thanks for
Thank
having
you.
us.
Thanks, guys. Before we wrap up, I just want to plug Nathan, who's been putting out some really cool educational videos on his YouTube.
Oh,
Two recent ones being cirrhosis, and then the most recent one being pulmonary hypertension.
I watched that one.
Especially for medical student learners. I'll put the link in the episode description for you guys to check it out. But thanks for joining us, guys. We'll see you next time.
Thank you.
Thank you.
Person, time, and place. See you next time.